Okay, we are starting with the important topic of proptosis. Okay, so the proptosis or acanthalmos is a forward bulging of the eyeball, forward bulging of the eyeball beyond our orbital margin, Okay, forward bulging. Okay, some literature uses the exophthalmos and proptosis as the same, and some consider it as different. Some have labeled exophthalmos as protrusion of the eyeball more than 18 millimeter beyond the lateral orbital margin, and the other literatures have labeled proptosis as the protrusion of eyeball less than or equal to 18 beyond the lateral orbital margin. Three things we have to look for in proptosis are the history, the physical examination using the Hertel thermometer to measure the proptosis, and observing the globe from below as the lids don't cover, or from behind, where more generally we prefer to looking the globe from below to see the proptosis. Like we are looking this from below. This is a mild proptosis of the right eye. This is a severe proptosis of both the eyes. This in the MRI we see the proptosis of the right eye. Okay, MRI will look from the foot end to the head end. So this is the right, this is the left, and this is the right eye proptosis in the MRI. We do CT or MRI as an investigation, and the final diagnosis is to be made with the orbital biopsy. Hertel's thermometer is this instrument. This is kept below both the eyes to measure the proptosis. It measures the interior projection of the eye from the lateral orbital margin to the apex of the cornea. Okay, it is likely push the instrument against the lateral orbital rim. Your lateral orbital rim. This instrument is placed. Make a width or base setting as narrow as comfortable. Width or base setting as narrow as comfortable. Use the same base setting for each patient each time. Average Hertel's measurements ratio differences are in Asians. It is 18 The distance between the interior projection of the eye from the lateral orbital margin to the apex of the cornea in the Asians is 18 in the Caucasians is 20 and in the blacks is 22 as the blacks have the shallow orbits. Asymmetry more than 2 between the two eyes is significant and is labeled as proptosis. The Lugde scale is also used to measure the proptosis. Here the apex of the scale is kept at the lateral orbital margin, and the distance between that to the apex of the cornea is measured. The proptosis can be axial and non-axial. The axial proptosis, the causes are the thyroid, the optic nerve tumors such as glioma, the intracranial tumors such as cavernous hemangioma, meningioma, and glioma. And the non-axial proptosis can be non-axial proptosis, that is the non-axial bulging of the eyeball. If the eye is bulging inferiorly, we have to look for the lacrimal gland causes, the tumors, the sinus infections, the frontal sinus infections, or the orbital roof tumors, or the encephalocele, or something like that. If the eyeball is bulging laterally, we have to think of ethmoidal sinusitis or the abscesses in the medial part of the orbit. If the eyeball is proptosed superiorly, we have to look for the orbital fat, whether it is coming out of the inferiorly and the eyeball is bulging superiorly, or some lymphoma. If the eyeball is proptosed medially, we have to look for anophthalmos, causes of ophthalmos, or the breast carcinoma metastasis. This is the figure showing the various extracoronal lesions, intracoronal lesions, and muscular disorders and their location. The extracoronal regions are outside the muscle cone, and they can be dermoid cysts, lacrimal gland tumors, rhabdomyosarcoma, or the extension of the nasal or the sinus disease. And the intracranial lesions can be cavernous hemangioma, optic nerve glioma, any arteriovenous malformations. The disorders affecting the muscles are the most common is the thyroid ophthalmopathy, the pseudotumor, the cysticercosis, or any lymphoproliferative disease. The unilateral proptosis, in which only one eye is bulging and there is a more than 2 difference between the two eyes. The causes can be any inflammatory lesion such as orbital cellulitis, abscess or cavernous sinus thrombosis, vascular disturbances such as hemorrhage, the varices, or the hemangioma, any cyst or tumor such as the dermoid cyst, osteoma, lymphoma, lymphosarcoma, glioma. meningioma of the optic nerve, retinoblastoma, metastatic deposits, systemic diseases such as leukemias, Graves' disease, thyrotropic exophthalmos in the initial stages, the paralysis of the extraocular muscles, the muscles will be lax and the eyeball will be proptused out. In the cases of complete ophthalmoplegia, any mucocele of the paranasal sinuses such as the frontal sinuses or the ethmoidal sinuses. Most common cause of unilateral proptosis in children is the orbital cellulitis, and in adults it is the thyroid ophthalmopathy. Then looking at the bilateral causes of the bilateral proptosis, it can be due to any congenital developmental anomaly of the skull such as oxycephaly, endocrine exophthalmos due to thyroid, any inflammatory lesion such as cavernous sinus thrombosis, any tumor such as lymphoma, lymphosarcoma, pseudotumor, nephroblastomas, Ewing sarcoma, the systemic diseases such as histiocytosis as seen in Hand-Schiller-Christian disease, amyloidosis, Wegener's granulomatosis. Most common cause of bilateral proptosis in children is neuroblastoma and leukemia, that is chloroma, that is AML M5. Okay, AML M5. And in adults, the most common cause is thyroid ophthalmopathy. The proptosis can also be intermittent, which presents as intermittent and rapid proptosis in one eye, and then it disappears and then it again comes. This is due to the venous stasis induced by the forward bending or lowering of the head, hyper extension of the neck. But basically it is anything that causes pressure and accumulation of blood in the veins, like coughing, forced expiration, or the pressure on the jugular veins. The example of this intermittent proptosis is orbital varix or the varicocele. The other differential is a pulsatile proptosis, in which the eyeball keeps on coming out and goes in again and again as a continuous motion. It comes out again and again. The differentials of the pulsatile proptosis can be carotico-cavernous fistula, any saccular aneurysm of the ophthalmic artery pushing the eye, pushing the globe outside and in, any meningocele, neurofibromatosis can be present, any traumatic or operative hiatus in the base of the skull or the apex of the orbit. The other term is pseudoexophthalmos. In this, the eyeball appears to be proptosed, but actually there is no forward displacement. What are the various causes in which this can occur? It occurs in ophthalmos because of the large eyeballs, as in congenital glaucoma, and in high myopia. Upper eyelid retraction, as in thyroid diseases, can present as pseudoexophthalmos. If there is present paralysis of extrinsic muscles, if there is a stimulation of a molar muscle by using cocaine, and if there is a shallow orbit as seen in craniofacial dysostosis. So this is the end of the orbit pathology. So we have covered the orbital anatomy and the orbit pathology, and so far we have covered, as per your MCI curriculum, the orbit has been covered. You have to read your books for this topic, and if there is any doubt, you can ask. You can ask by communication through the messages or your WhatsApp group. Okay. The only mantra in any medicine field is read when you can, and just read and read, and you can, in the practical classes, the practical points you can pick up. Okay, and so far I have covered both embryology and the orbit. The next topic assigned to me is trauma, and we will meet soon with it. Till then, stay safe, stay strong.